This is the human side of healthcare, where we explore all aspects of today's ever-changing healthcare environment. Brought to you by the Dallas-Fort Worth Hospital Council and featuring CEO Stephen Love with co-host Thomas Miller. Now, let's make healthcare human again.
And welcome to the human side of healthcare. We're delighted today that we've got the president and CEO of the American Hospital Association with us, Mr. Rick Pollack. Rick has done an excellent job, especially leading all of the hospitals across the United States during this COVID-19 pandemic. Rick, welcome to the show.
Thanks very much, Steve. I appreciate your asking me to be with you today, and you've been a great partner, and appreciate all of your leadership. You've made so many important contributions at the local, state, and national level. Thanks so much.
To our listeners, how would you grade how American hospitals and health systems have been faring as we continue to see increases in COVID cases throughout the country?
Well, to state the obvious, this past year has been a real doozy as we face not only an unprecedented public health crisis coupled with an economic crisis and the need for the nation to squarely face up and address issues involving social justice stemming from cultural and racial tensions, not to mention what could be a constitutional crisis. And, in the midst of all of this, hospitals and health systems as cornerstones of our communities have played an incredible role. And we continue to focus on healing and hope rather than fear. And I just want to say that we really owe an enormous amount of gratitude to all of the frontline workers, the healthcare heroes that have worked so hard to protect patients and communities. In terms of how hospitals are faring, it continues to be a crisis of unprecedented magnitude. We've got an increased number of cases, an increased number of hospitalizations, certain hospitals in parts of the country reaching full capacity. We have, difficult situations in parts of Texas, particularly El Paso. Staffing continues to be perhaps our biggest challenge. I guess the good news, Steve, is that in the midst of all of this, we have learned a lot along the way. We've made significant improvements in caring for patients from a clinical perspective, and I think that we've seen our hospitals truly become the indispensable trusted partners to the communities they serve.
Rick, I couldn't agree with you more. I think they truly are a trusted partner. You and I both have known that prior to even facing COVID-19, hospitals face some key long-term challenges. How would you say the pandemic has made these pressing to tackle, or how do we deal with them now?
It's interesting you mentioned that because, when we talk about our strategic framework for tackling COVID, we talk about the 3 R's and then we talk about the big three. And the 3 R's are really about relief, which we have focused on in terms of providing regulatory waivers, many of which we want to make permanent. Relief has focused on providing hundreds of billions of dollars in financial relief that we continue to work on. The second R is around recovery, and that is how we balance the need to be COVID ready in a constant state of emergency readiness, but also be COVID safe as we have to provide regular care to the sick and injured and keep people healthy and maintain our financial viability. And then the third R is rebuilding, which is, as we go through this, what is it that we reevaluate in terms of the way we do things, and how do we reimagine things from this experience to create a better system for the future? But to get to the heart of your question, the big three that goes with the 3 R's are 3 issues that existed, as you said, before COVID that just got exacerbated in terms of the seriousness of them. One is the workforce and the issue of resiliency. The second is behavioral health. We know that as a result of this whole situation, we have an increased number of people suffering from a variety of different mental health conditions. And the third is health equity and disparities. We've seen how that has affected, how the virus has affected certain vulnerable community. So all three of those, we were all working on them before, but they just got more challenging.
I know you interact with hospitals throughout the United States, and this pandemic is far from over. But are there any lessons that you think the hospital field has learned thus far during this pandemic?
Well, I think there'll be plenty of after-action analysis reports in terms of the experience. And since it's ongoing and we keep learning, we're not there yet in kind of finalizing them. But I do think that one of the things, as I mentioned before, that we're learning is to coexist with COVID. And that's something that we have to recognize in terms of the fact that in the absence of a cure or the absence of a vaccine, we have to learn how to coexist with it. I think that we're entering eventually a new era of emergency preparedness. We've learned that the stockpiles that have been maintained have not been adequate and have not been properly stocked, let alone useful in a significant way when it came to emergencies. We're learning that we have a patchwork system of care that lacks coordination, that's going to need to get tightened up as we deal with people that have chronic conditions emerging from the virus. We're learning how to create new care models through the creation of alternative sites of care and also through the expansion of telehealth. We're learning to create new staffing models with an increased role for allied health professionals and the ability of all licensed providers to provide care to the top of their license. We're learning how to provide better care at home as we try to make sure that hospitals are only handling the most acute cases. We're learning that we have to diversify the supply chain. Never again could we really rely on just one or two countries to be the supply chain for a variety of different medical supplies and equipment. And I think we're also learning that we've got a public health infrastructure in many parts of the country that is truly underfunded, if not dilapidated. And in many cases, it's forced our hospitals and health systems to step into the gap and become the de facto public health system for many communities.
Thomas, he's a great guy. I've known Rick for 15 to 20 years, and he really has got the pulse of the hospitals throughout this nation. And one of the things that we're still focused on is COVID-19. He told you how hospitals are working throughout the nation. Thomas, here in North Texas, we're still having volume increases. Our positivity rates are up. The RT factor is 1 or above, which means community spread is there. We're coming off of Halloween. We've got Thanksgiving coming up. I got to tell you, Thomas, we got a lot of work to do.
And we're going to talk in the next segment with Rick about vaccinations, which are also part of the key.
Vaccines are key. What we've got to do, though, Thomas, is coexist with COVID-19 until the vaccine.
More with Rick Pollack from the American Hospital Association next on the human side of healthcare.
This is the human side of healthcare on 1080 KRLD and the radio.com app, where we feature healthcare's hottest topics and what our North Texas area hospitals are doing to make healthcare human again.
And welcome back. We're talking with Rick Pollack, who is the president and CEO of the American Hospital Association, and we're going to pick up with the hot topic of the conversation of a potential vaccination in 2021.
We've got to coexist for a while, unfortunately, with this virus and all work together until we get a vaccine. So what's, in your mind, the current status of the vaccine development?
In terms of the development of the vaccine, there are literally multiple vaccines that are going through the testing process, at least a dozen or so. And, everybody is hopeful that one or two or three will emerge as being effective when it goes through the appropriate process. And everybody, of course, is very concerned that we maintain the integrity of the safety process to ensure that the vaccines are, in fact, appropriate. Everybody is expecting something perhaps to be available at the end of the year, but that doesn't mean that it's going to be widely distributed at the end of the year. I think we're going to be dealing with this certainly into next year and through possibly the summer. And there are a lot of challenges associated with the vaccine aside from ensuring the safety of it. We certainly want to make sure that healthcare workers and emergency responders are first in line in terms of receiving the vaccine. We're going to have to make sure that there is proper refrigeration for this particular vaccine, which puts an additional responsibility on hospitals and health systems because they may be the ones that are best able to maintain that level of refrigeration for the first generation or two of these vaccines. We're going to have to make sure that there are enough, refrigerated trucks to make sure that the vaccine gets out into isolated rural areas. Once we're assured that this vaccine is safe, we're all going to have to band together, certainly with doctors and nurses as we have before, to educate the public on the fact that the vaccines are in fact safe. And then there'll be other challenges, I'm sure, along the way. Some of the vaccines require one shot. Some of them require two. If they require two, making sure people get the same type of vaccine and tracking the information about who gets it. So we've got a long ways to go. We're confident that in the case of the vaccine, that science will save us, in the words of Ian Morrison. We just don't know when.
That's a great quote by Ian Morrison. That is fantastic. Rick, I'm going to pivot on you just a little bit. Can you talk a little about the politicalization of public health and how the American Hospital Association and hospitals are navigating this challenge of, politics versus public health?
Sure. Well, one thing that we're steadfast on is that regardless of the political pressures, we're going to be guided in our efforts to fight the pandemic, similar to how we've defeated previous threats to public health, and that's by following the science and the advice of clinical leaders and public experts, period. That's the only way in which we will be effective in this effort. And it's extremely disconcerting to see people politicize the use of masks or possibly politicize the safety process involved in approving the vaccines. We've been very active in working with the American Medical Association and the American Nurses Association in mask up campaigns to encourage everyone not only to mask up, but to follow the guidelines relative to hand hygiene and social distancing, physical distancing. So we have to follow the science. We have to listen to our clinical leaders, and we have to listen to our public health experts. And I got to say, we're also, along with the American Medical Association, very distressed at recent comments made by some that doctors are profiting, if you will, from taking care of COVID patients. That's just totally false and irresponsible and quite offensive to so many of us.
Rick, you're so right. I was thinking about where the American Hospital Association and you specifically address some of the misinformation coming through social media. And, I think we should be saluting those healthcare heroes. And I think many of our listeners may not understand this, but for Medicare patients, you get reimbursed on diagnosis. It's called a DRG. And it has nothing to do with the coding related to COVID-19 or if the patient dies, etc. So thank you for the statement that you and the American Hospital Association put out to just give people the facts. Thank you for that.
Sure. And of course, there are a lot of legal accountabilities that we're responsible for when it comes to how we code for these cases, and we take those very seriously.
Rick, you and I have known each other a long time. The election is over. How is it going to impact the future of healthcare, and specifically how you think it's going to determine future actions related to hospitals and providers?
And I think there are some general trends that we're seeing in healthcare policy that we have to keep in mind, and they're going to continue. One is that the role of government is going to increase, but we're still going to have a private healthcare system. Second is we're going to continue to see an acceleration toward what we call alternative payment systems. In other words, moving away from fee-for-service payment toward value-based payment that provides incentives for better quality and for coordinating care. We're going to see an increased presence, I think, of Medicare Advantage. We're going to see an increased emphasis on primary care and the social determinants of health, recognizing that there are a lot of non-clinical aspects of taking care of people that are important in maintaining one's health. We're going to continue to see the increased entry of new players into the healthcare markets, if you will, many of whom are reviewed as disruptors, and whether they are, CVS, Walgreens, Google, Microsoft. At the end of the day, I do believe that, again, hospitals are the indispensable, trusted partner, and we will continue to play a role in saving lives, performing miracles, and keeping people healthy.
I think Thomas had a question.
Sure.
Rick, if you drive through any town in America, but especially the smaller and mid-sized towns, and you look up who the major employers are, toward the top of that list, you're going to see the healthcare systems. How has COVID and this whole experience of 2020 affected that relationship of the hospitals with their communities?
Well, I think it has enhanced it, again, because at the end of the day, we are the indispensable trusted partner that everybody looks to in any emergency or in any critical condition. And whether it's setting up, testing sites or whether it's taking care of people, I think it's only enhanced it. And frankly, we do a fair amount of public opinion research, and the level of confidence that people have in hospitals today is extraordinarily high. And so much of that, of course, is not because they have confidence in the building, but because they have confidence in the professionals that are in that building. The doctors, the nurses, the respiratory therapists, the pharmacists. And I think that people have seen the value of America's hospitals more than ever before.
Thomas, it's always great to talk to Rick and get his keen insights. But, as we look to the future, especially as we look to 2021, providers, hospitals, physicians, we've got to look at how do we transition even more to value-based payments? How do we look at some of these Medicare-type Advantage plans? How do we focus more on primary care? There are a lot of new players entering healthcare. We call them disruptors. And, we've always been and will continue to be the trusted partner in communities where we have a significant economic impact.
We said in the interview that hospitals are among the top employers in any community, basically, in this country. So what is the economic impact?
Thomas, great question. We usually do just for hospitals only, not the entire healthcare sector. But we take our member hospitals and do an economic impact study about every 3 years. And we were going to do one this year, but because of COVID-19 and so much going on, we just thought not a good year to do it. But the last time we did it, the 90 hospitals and the DFW Hospital Council inject close to $15 billion annually into the North Texas economy.
And we're bringing you this show called The Human Side of Healthcare so that we can share some of these topics with you and give you a little peek behind the curtain of that big employer and economic driver in your community, the hospitals. And let me take this quick opportunity to remind you of our podcast. Chances are we are on your favorite podcast player. Just search for The Human Side of Healthcare. Now, when we come back, we're going to be talking about sports injuries. Again, something that is relevant in the fall, particularly injuries that are on the increase, concussions.
And we're going to have Dr. Shane Miller next on the human side of healthcare.
The DFW Hospital Council, along with our over 90 member hospitals in North Texas, are proud to bring you the human side of healthcare with Council President and CEO Stephen Love and co-host Thomas Miller.
And welcome to the human side of healthcare. We're delighted you're with us today. And today we're going to talk about concussions in sports, brain injury, and accidents that do occur with children. We couldn't have a better expert than Dr. Shane Miller, who's the sports medicine physician at Scottish Rite for Children. Dr. Miller, welcome to the show.
Thank you. I'm happy to be here. I appreciate you having me.
How do sports-related concussions most commonly occur?
Well, typically there's a direct blow to the head, and this may occur from contact with another player, for example, head-to-head while playing football or being struck by somebody's elbow or a knee. Sometimes it may be as they fall and strike their head on the playing surface, whether that's a basketball court or the volleyball court or the football field. And sometimes they can be struck by an object, whether that's a ball, a soccer ball, or it could be even a lacrosse stick or something along those lines. But usually there's a direct blow to the head, and that causes shaking of the brain. To concuss means to shake, and the brain is sort of shaken somewhat inside the skull, which causes an injury. And typically, concussions we think of as a brain injury that causes problems with the way that the brain functions or the way the brain works. And most of the time during sport-related concussions, it's a little bit of a different injury than we may see in more severe brain injuries, such as in a motor vehicle collision.
You know, when we think in terms of concussions, I know I always kind of think about football, but what other sports that you treat children from have high rates of concussion?
Well, you are right. And being here in Texas, certainly football is number one. And we certainly see a lot of concussions related to playing football. But any of the contact sports, we will see a lot of concussions. And so soccer, basketball, hockey, lacrosse, wrestling, sports that have more contact with opposing athletes and players are going to increase that risk of a concussion much greater than a non-contact or low-contact sport such as tennis or even sports like baseball.
So what about when you think in terms of girls versus boys?
Well, again, I think a lot of us think about football, and that's what we see in the news and the media. There's a lot of coverage on football players and concussions. But absolutely, this is an issue that we see with the girls. And surprisingly, as I mentioned, football is number one for what we see here, but girls soccer is number two. And it's actually a very close second to football. We see almost as many concussions in female soccer players as we do in the football players. And when you look at the girls playing sports that the boys also play, for example, soccer and basketball, the girls' concussion rates are much higher than the boys, twice as high, for example, in soccer and basketball than the boys. And we don't understand exactly why that is right now. There are several thoughts and hypotheses about why that may be. But I think that what's important is that we understand is that we need to continue to focus on paying attention to this is an issue with the girls and researching girls and not just paying attention to football.
Dr. Miller, what are some of the signs or symptoms that would tip us off to a possible concussion of an athlete in any sport?
There are several things that may clue you in that a concussion has occurred. Typically, the symptoms occur fairly quickly after the blow to the head or the fall and may develop over minutes to hours after the actual injury. Obviously, if somebody has been knocked unconscious, then that may be an indication. But most patients who have had a concussion do not lose consciousness. So you're going to look for somebody who may seem a little bit confused or disoriented. They may grab their head. They may sort of have a dazed look on their face, may have some balance problems or unsteadiness when they get up. The person who has been injured may complain of a headache very commonly, may have some difficulty with memory, concentration problems, vision changes. A lot of times they'll complain of light or noise sensitivity, sleep disturbances, And sometimes they'll be a little bit more irritable or have some emotional changes. Concussions really can present in a lot of different ways. And so it's important to be aware of the concussion and really think that any time that somebody has had a blow to their head or a fall where they may have hit their head, it's something that we want to observe for any of these signs or symptoms and keep a close eye on them so that we can pick up on them early and manage them accordingly.
If someone suspects that an individual, especially a child, is exhibiting signs and symptoms of a concussion, what should they do?
Well, the first thing that we want to do is make sure that they're safe. And we typically say, when in doubt, sit them out and keep them out. So if it's in a sporting activity, a game or a practice, we want to remove them from play immediately. And obviously, if the child has been maybe knocked out or has neck pain or has severe pain, you may not want to move them, and you may want to have somebody evaluate them with medical knowledge and make sure it's safe to do so, that there's not a neck injury or a more significant injury going on. But in general, if it seems like it's an injury where they've kind of gotten up on their own power and are doing okay, we want to remove them from play. All too commonly, we will see somebody will be evaluated briefly, and a well-meaning coach or parent may ask the child, how do you feel? Do you feel okay? Do you feel like you can keep going? And then, of course, a child will say, yeah, I feel great. And then they'll be allowed to continue participating in whatever activity they were injured. And we really want to discourage that and try to get them removed from that activity so that they are not risking worse injury as they continue to participate. We do recommend that anybody with a suspected concussion be evaluated by a healthcare professional who does have experience evaluating and treating concussions before they return to their normal activities, whether that may be sports or driving or school or work.
If you suspect a concussion, do all have to go to the emergency room or emergency department? What are your thoughts about that?
I do not think that they all need to be seen in the emergency department. And actually, a lot of the studies that we have seen show that the majority of people who have suffered a concussion do not present to the emergency department and may be managed by their PCP. Now, there are certain things that do need to go to the emergency department, and those are the more severe symptoms, patients who may have some signs or symptoms that are concerning for a brain bleed or a skull fracture or something more significant that may need intervention and observation in the emergency department. Adults are a little bit different and have higher risk of some of those more serious injuries. And so the threshold for an adult to go to the emergency department may actually be a little bit lower, especially an older adult. Most kids who get injured playing sports do not need to be seen in the emergency department, but there are certain what we call red flags, sort of warning signs to watch for that may indicate that they should be evaluated and perhaps may need some imaging. And these may include worsening symptoms, such as a severe headache that's worsening, increasing confusion, repetitive vomiting, difficulty walking or talking, or really anything that they seem significantly different and are not improving fairly quickly after the injury. But really, I typically will tell parents, anytime that you're worried, if you're worried enough, then you should probably go ahead and take them in to be evaluated, because I would rather you go into the emergency department and have them tell you that everything is fine than to be wavering and not make that decision, and if that's the place that you need to be. So anytime if the parent is concerned, I think that's a reasonable consideration.
What does the overall treatment of a concussion entail?
The treatment has changed quite a bit, even over the past decade, several times. And not long ago, we were insisting upon a lot of rest and downtime and pulling everybody out of school and out of their normal activities. And what we found is that humans in general and concussions don't respond well to that. And so although a little bit of rest is good for the brain, and we certainly want to protect them from further injury, we allow the patient to do what their symptoms allow them to do without getting a lot worse. And so, for example, if they can tolerate a little bit of reading, it's safe to do that. And we don't worry as much about that. We are taking a much more active approach to rehabilitating and treating concussions now. We will evaluate the patient or wherever they may go and be evaluated. And depending on how they are presenting, what their symptoms and what their exam are telling us, helps us individualize and really make a more patient-centered treatment approach. And again, I think sometimes occasionally we use medications, but a lot of times this is more in terms of active management. So for example, we now are getting patients back to exercise much sooner than we previously did. We have found that not only is some light exercise early on in the recovery period safe, but it's also likely beneficial in their recovery. And so especially our young athletes who are used to practicing and playing every day, if we shut them down and have them not do any exercise for several weeks, then that could be actually more harmful to their recovery. So if we can get them doing some light cardio activity where we may put them on an exercise bike or doing something very light that doesn't make their symptoms worse, that's a positive intervention to do. We also want to get them back to whether that's school or work soon. After maybe no more than 2 to 3 days of rest, we want to re-engage them. The brain responds well to some stimulation and some activity. And when we have it shut down and not doing anything, that is not helpful in the recovery. And so one of the things that we really look at is this is not an all or nothing approach. So it's not that you can either be at school doing everything normally or at home doing nothing, but there's certainly a whole gradation in there that we can gradually increase activity as they improve and as their symptoms allow.
You're listening to Dr. Shane Miller, who is the sports medicine physician at Scottish Rite for Children, and this very important conversation about protecting our kids from concussions continues on the human side of healthcare. Stay with us.
We're continuing our conversation on how you can empower yourself to have the best health possible in today's ever-changing healthcare environment. This is the human side of healthcare with DFW Hospital Council President and CEO Stephen Love and co-host Thomas Miller.
And welcome back. We're continuing our conversation with Dr. Shane Miller from Scottish Rite for Children about concussions and sports injuries. And we continue with that question that every parent and kid has. When can I go back to sports?
Let's assume a child has sustained an injury, a concussion. What are the general factors or maybe the checklist that influences your recommendation on when that athlete can return to play?
Well, we always think about a lot of the times these are student athletes and school is a priority for them. And so, my order of priorities for the patient often is healing and recovering from their brain injury is number one, and then getting them back in school is number two, and then returning them to sports is number three. And sometimes that's the opposite order of what especially my teenage athletes may want to do. They want to get back to their sport immediately. And so we do sort of have to make sure that the brain has fully healed and recovered and that they're tolerating schoolwork before we'll consider putting them back into an environment such as their sport where they may be at risk of another injury. And so we're looking at their symptoms and how they are feeling, how they are responding to day-to-day activities. We are looking at how their exam is. We will utilize different tests in the office and looking at memory, looking at reaction time, looking at the way that the brain is functioning, looking at their balance, looking at their vision. So really it's a comprehensive assessment of the patient in addition to how they are feeling to make sure that we can, as best we can tell, they have recovered from their injury. As they're tolerating a full day of school, a lot of times when they initially will get back to school, we will be limiting what they can be doing while they're there. But once they're tolerating full schoolwork, homework, tests, etc., without any symptoms, then we will talk to them about getting back into sports. But again, all of those other boxes, so to speak, need to be checked prior to returning them back into sports.
Many of the professional athletes unfortunately sustain concussions. And there are some quarterbacks that have had such frequency of concussions, they had to retire and end their career early. That kind of sets the basis for this question. Kids or adolescents that participate in youth sports, if they have more than one concussion, is that something that's a red flag about maybe they should not participate anymore?
Well, that's a great question, and it's a conversation that we have frequently with parents and children. I think that one of the concerns is, what are the long-term risks? There's more and more reports and news reports coming out about what we call CTE, chronic traumatic encephalopathy, that you hear in the retired NFL players and hockey players and such. And there remain a lot of questions about the long-term risks, because there are certainly many, many athletes that participated in sports throughout a young life in high school and even in college who are doing just fine, who do not have any long-term effects related to their participation in those sports, including football. And so trying to identify is, what are the risks and who may be at risk? And because maybe it's not everybody that it's at risk. So when we are making that determination, it is a complex discussion with a child, but I do get concerned when I have a 11 or 12-year-old who comes in who may already have had 3 or 4 concussions before they've ever entered into middle school athletics. And that child may have a lower threshold, for example, to get a concussion. And if they have another 6 years of participation before they even graduate from high school, it is likely they're going to continue to sustain more injuries. But there's not really a specific number. I think in the past, a lot of people would say, oh, you've had 3 concussions, you're done. But we really look at a lot of factors. We look at how have the injuries occurred? How quickly have they recovered? How far apart are the injuries? What are the long-term goals of the child? And we look at trying to make sure that they fully recovered between each of these injuries. But we may have that conversation after 1 or 2 injuries if perhaps this is not the sport that the child wants to participate. Maybe the parents have dreamt that this child is going to be a collegiate soccer player, but the child loves doing something else. That may be a nice time for them to transition to a different sport. But if that's the child's goal and dream and they seem to recover quickly and they don't show any signs that they are having long-term effects from their previous injuries, then we do feel comfortable returning them back to participation. Again, because we have a lot of data that shows many people who have had concussions and have played in sports throughout their youth and high school careers go on and do just fine. So we are weighing the risks and the benefits of continued participation in a particular sport. And certainly a lot of sports do bring different risks, and we have to determine if the benefits of continuing to play for that particular individual outweigh those risks or vice versa. And that's a conversation that we have.
Based on the research and based on your data, do you think it would be appropriate for physicians and sports medicine doctors to influence some of the rules and rule changes, not only at college, but high school and even elementary type sponsored events?
That's a great question. And we are all interested in making sports safer. And we may have different reasons for that, but I think that the authorities, the governing bodies of the sports and the administrators and the coaches, as well as the physicians and of course parents, we do have a vested interest in making sports safer. And although we cannot prevent all concussions, certainly we would like to reduce the risk of injuries. And there have been some changes historically in different sports. For example, there were lots of neck injuries back in the early 70s before they implemented the spear tackling rule. And they saw a drastic reduction in cervical, spine, or neck injuries. And making changes in terms of the kickoff rules in the NFL, you can see a significant change in the number of concussions there. So what we need to do is, in this age of data, where we have the ability to gather data at just such a high level, is understanding what does that data mean? Where are we seeing these injuries occur? And are there ways that we can implement rules that will reduce the risk of an injury without significantly changing the game. We want to keep these games around, but we want them to be safe. And so football is not the only sport that we think about that. Hockey, for example, body checking, young children body checking when they don't have the control to protect themselves. So in some of the leagues in the younger ages, they have eliminated body checking until a certain age and have seen reduced concussion risks. You look at soccer, there have been the consideration on taking out headers, younger children who may not have the neck strength to control their head and to head the ball and have the body control to do that. If we introduce heading at a little bit later age, then perhaps we are now going to reduce that risk of a concussion for them. I think the biggest one that people have been talking about lately is tackling. Is there a certain age or a grade perhaps that tackling should be introduced in American youth football? And even some states, not in Texas, but several states have introduced legislation with the idea that maybe we shouldn't start playing tackle football till the age of, for example, 14. And so that's one of those that needs to be studied, and we need to understand what are the implications of making that change, and does that make sense before they're 14, and does that increase the risk after they go back to or introduce tackling? But these kinds of ideas, I think we all need to be open to changes in understanding the data, but not reacting too quickly and making changes without having the data to support our recommendations.
Dr. Shane Miller from Scottish Rite for Children, thank you for your excellent comments on concussions, protecting our kids. That's what all of us want to do. Steve?
Well, Thomas, I'm a broken record, but wear a mask, physical distance, wash your hands, get your flu shot. I know you're tired of hearing it, but I'm going to keep saying it. We got to do it.
Well, and the thing that's concerning to me is the national experts are now saying that we're going to have a more severe wave, of course, looking at what happened in 1918 and saying that the second wave is worse.
Absolutely. That's the primary focus. Prevention, prevention, prevention.
All right, we'll leave it with that. Steve, you have a good week, and we will see all of you back here next Sunday at 1 and 7 on 1080 KRLD
and radio.com.